I'd now like to introduce Karen Brown. She is the Program Director and a Professor in the Medical Laboratory Science Program at the University of Utah School of Medicine, Department of Pathology, responsible for teaching hematology, hemostasis, phlebotomy, education, and introductory courses. In addition to teaching in the Medical Laboratory Science Program, she frequently presents local, regional, and national webinars in the areas of hematology and phlebotomy. Mrs. Brown also has extensive experience in leadership positions for professional organizations and continues to be actively engaged as a member of numerous committees and work groups. She received her Bachelor of Science degree in Medical Technology from Nebraska University and her Master's in Clinical Laboratory Technology from the University of Dayton. I'll now turn our time over to Karen.
Thank you, Holly, and good afternoon, Tricor. Welcome to this phlebotomy webinar. I am delighted to be presenting, and as Holly mentioned, one of my responsibilities in our medical laboratory science program is to teach phlebotomy. Phlebotomists often face many challenges and endure all types of remarks and comparisons. And one of the comparisons I remember in the days that I actively worked as a phlebotomist was the highest praise that could be bestowed on any phlebotomist was being able to draw blood from someone whose veins were like that of a turnip. And just to underscore the fact that there are so many challenges that we have. I also recall another instance when a patient said to me as I entered the room, "Here comes the white mosquito," as I entered the room. Well, as I was thinking about this webinar and preparing, I actually wondered if there was anything like a white mosquito. So as you know, you can find almost anything out today on the internet. And sure enough, there is something called, or a bug called, a white mosquito. Technically, it is the Asian tiger mosquito. And because, if you notice very closely, you can see a stripe, a white stripe down the back, and you can see some alternating black and white bands on the legs. This mosquito was introduced here in the United States in the 1980s in a cargo of tires that were shipped from Asia. So if you are called a white mosquito, there really is such a thing. Now, to be a little more serious in what we're here to accomplish today, as I thought more about this webinar, not only do phlebotomists have challenges, but phlebotomists, of course, are very important members of the healthcare team and are key professionals on the team for healthcare. And I sometimes sense that the phlebotomists who attend my sessions are really not the ones who need to be completing continuing education. So I applaud all of you for participating in this webinar, taking time to be the best phlebotomist that you can be. I believe it is the true professional who seeks education and ways to improve their skills, to build their knowledge. And it's the phlebotomists who are properly trained and regularly participate in continuing education that keep their skills sharp. And it's these individuals that truly do work within the standard of patient care. As I mentioned, phlebotomists face numerous challenges. And to help us address some of these challenges, we'll be looking at these different areas and specifying and addressing challenges for all of us as phlebotomists in these areas. And so our objectives for today are as indicated. But before I really get into detailing some of these challenges, I want to take a little bit of time to address patient identification because it is certainly central to the phlebotomy procedure. It's so important, and to remind all of us about the proper patient identification. So again, only identifiers that are attached to the patient are going to be acceptable. 2 identifiers are required. And it's important to resolve any discrepancies, even if they appear to be minor, before continuing. So for instance, if I was identified as Karen C. Brown instead of Karen A. Brown, then it would be important to resolve that issue before continuing. The last time that I had my own blood collected, I noted that I had to state my name for the phlebotomist, I had to state my birth date, and then after the venipuncture was completed, I was asked to verify again my information on the collection tube and to initial the request form to indicate that I had verified. So I think it's important in any phlebotomy setting that the patient or family members, if necessary, are actively involved in patient identification. Of course, there are problems in patient identification, and the biggest problem, of course, can be that the patient has no ID band. Studies have shown that wristbands, even when they are attached, however, can be unreliable in the information they have. And a study that was conducted, particularly looking at blood banking samples that were collected, estimated that there was an error rate on the ID band anywhere from 0.5 to 16%. There are also in situations in risk in which there are problems that can arise. So for instance, there are siblings or twins that both have appointments at the same time, if we're talking about an outpatient setting. Or we talk about common names like Karen Brown or Joe Smith. You can also have look-alike or sound-alike names. So for instance, somebody is named Tommy Jones, T-O-M-M-Y, Jones, but then maybe somebody else is Tom E. Jones. And so it's very important to check the information that's going to be available on the band. Sometimes we also run into inpatient healthcare providers, nurses and doctors that are pushing the phlebotomist to obtain the specimens as quickly as possible. And then many of you, I'm sure, can think of other situations that can be problematic in patient identification. One issue that we run into sometimes at the University of Utah Hospital, and the phlebotomy services are provided by ARUP at University Hospital, is that the labels that are used to affix to the tubes sometimes stick together. And so we miss sometimes labels because of that. So there are many instances in which patient identification can become problematic. Studies show us how important patient identification is and also emphasize the challenges to proper patient identification. And I've cited some numbers already, but I also want to cite some additional studies. In a 2010 College of American Pathologists Q-TRACK study that was reported in Laboratory Medicine in 2010, monitored 217 institutions and found an initial identification band error rate of 7.4%. The most common problem that was associated with this error was that bands were just missing. Overall, estimates suggest that more than 160,000 adverse patient events occur each year in this country and are due to patient or specimen identification errors and that directly involve the laboratory. Fortunately, and thank goodness, 85% of these mistakes are going to be caught before there's any harm done. But what I want to question and what I ask is, what about the remaining 15%? That's a pretty high number, okay, to have error rates. So some information to think about as patient identification. All right, our first Q in the quandaries. And there are several issues to consider after we have properly identified our patient and we need to select the vein. And I don't think any presentation that deals with phlebotomy can not discuss a little bit, at least, about the venipuncture procedure itself. And certainly, the venipuncture procedure is invasive. Infection is always a possibility. And I think sometimes we minimize this, but because of the invasive nature of this procedure, there is that chance of infection. And our veins need to be used for other purposes many times, particularly in our hospital population. The veins are used to administer transfusions and medications, and if they become damaged or impaired, it can also impact these other procedures. So if we look at the veins in the arm, and the first thing I want to mention is that when I put preferred and optional on this slide, I didn't really intend to make the ones, the cephalic showing on the left and the others on the right listed as optional and preferred. I'm just stating that there are preferred and optional veins. I consider that optional is always the basilic, and it's best to avoid this vein altogether if there are other veins that are accessible. It's in close proximity to the brachial artery. It's also very close to the median nerve, so it really should just be avoided. I think the median cubital is the best vein to use. It's well anchored. There's lots of supportive tissue in that area. And of course, the cephalic can be used and the median antebrachial, but I think the median antebrachial, being usually a little bit lower on the forearm, provides a little more discomfort. So if I would have to rank the veins, preferred is always going to be the median cubital, then the cephalic. Optional is always basilic. And then again, median antebrachial could be used, but I don't usually consider it in either category. When we look at veins in the hand, I consider all veins in the hand as well as veins in the foot and leg as optional. The back or the dorsal side of the wrist can be used based on your own institution's policy for obtaining blood from the wrist. Veins in this area do tend to roll, so anchoring is going to be very important. We always want to avoid veins that are on the underside of the wrist because they are close to the radial and the ulnar arteries. There is less supportive tissue in that area. There are nerves and tendons, and so always on the underside of the wrist should be avoided. Ankle and foot veins are only used if arm and hand or wrist veins are unsuitable, and again, you must have permission or follow the policies of your institution. Now, what can happen if we accidentally puncture an artery? And first of all, arteries are spongy, they have a pulse, they're thick, they do feel different than veins. But if we happen to puncture an artery, the tubes are going to fill very quickly. We may also develop a hematoma very quickly at that site of puncture. So we want to stop the venipuncture immediately, we want to remove the needle, and we have to apply pressure. And pressure should be applied for at least 5 minutes or until active bleeding has stopped. If we accidentally puncture a nerve, well, for one thing, the patient experiences shooting, electric-like pain, and tingling and numbness that's proximal or distal to the puncture site. So you're going to know if a nerve has been punctured. The patient will let you know that right away. So you want to stop the venipuncture, remove the needle, and if necessary, of course, repeat the procedure at another site and follow facility policies for documenting the incident. It may also be necessary to direct the patient for medical evaluation. When we talk about venipuncture in general, it's important, I think, to remember that all patients are unique, and vein selection is going to vary from person to person. So don't be afraid to feel for a vein. And in fact, I use what is called my feely finger. So I'm right-handed, and so my feely finger is actually on my left hand, and it's my index finger. And so this is the finger that I've used to become most sensitive, if you would, to feeling for the veins. And it's important to feel and not to be afraid to feel. And it's also important sometimes that we feel both arms to adequately find the vein. Because of the potential for injury that's associated with all veins, we want to be able to find the vein that is most likely going to be punctured without any injury or incident to the patient. It's also important, of course, that the vein we select is one that we're comfortable with selecting and puncturing and that we feel confident about using in the procedure. So this is actually my arm, and my colleague is pointing to my median cubital, so hopefully you can see it in the middle there. So again, I believe the median cubital is always the best one to look for initially. As I mentioned already, phlebotomists do encounter numerous risks during the venipuncture procedure. And certainly these risks can be minimized with the safe use of equipment. So I want to talk a little bit about some of the equipment that we are using in the phlebotomy procedure and a few reminders about the equipment that we use. Gloves, of course, help protect us against bloodborne pathogens. And it's important that they are used for the entire procedure, that we do not alter the glove by cutting off the tip, because that can compromise the efficacy of the glove. We don't want to wash them because that can open up pores in the glove and compromise their effectiveness. And of course, the gloves need to be discarded when we are finished with the procedure. Needles, of course, have evolved over the years, and we have safety needles that are available for us to use. And I have a few comments, some information to share about needles from the standpoint of a little bit of history. In November of 2010, the Needle Stick Safety and Prevention Act became law. And this legislation was mandated by the Occupational Safety and Health Administration, or OSHA, to revise the bloodborne pathogen standard and require healthcare facilities to use sharps with engineered sharps injury protection features. Well, a conference that commemorated the 10th anniversary of this law was held in November of 2010. And in conjunction with this conference, there was a lot of very interesting information that was released and a lot of statistics that were cited. And I thought this was kind of interesting to go back and look at this a little bit. The Needle Stick Safety and Prevention Act has led to a 34% reduction in accidental needle sticks in the United States. So I think that's a significant number. And specifically, needle exposures during phlebotomy are down 60%. Also in the United States, 87% of needles used are safety needles. So that's a lot of progress. But there again, the question I ask is, why is it not 100%? Why is there 13% noncompliance with use of the safety needles? And I'm sure many of you have your own thoughts of why we might see this noncompliance. But let's visit this for just a minute. Our needles need to be reliable. They have to be easy to use. The safety devices have to be easy to use. They have to be easy to dispose of. They have to be constructed to not interfere with our venipuncture procedure. So there are a lot of constraints that affect the compliance issues. How and when do we have risks that are associated with the venipuncture procedure and using our needles? Well, it is amazing to me actually that sometimes we still see these risks and see individuals that remove needles from holders. They accidentally contact the back end of the needle that's covered by the rubber sleeve. They bend or break needles. They fail to properly activate the safety device. And it's kind of interesting that in a reference from Advance magazine from July of 2010, nearly 57% of injuries from safety devices occur before the activation of the safety device, and then about 26% occur during activation. So there is a clear need for training and buy-in by individuals that are using the safety devices so that they use them properly. And of course, recapping needles sometimes are done improper needle disposal, and then many other possibilities as well. For instance, the patient moves or jerks during the phlebotomy procedure. And of course, that's out of the hands of the phlebotomist to a certain extent. So the precautions that we can initiate are important because it's estimated that the cost to follow up and treat potential needle stick injury or a needle stick injury can range anywhere from $71 to $5,000. So that's a significant amount of money. The money does not account for the loss of productivity. It also does not account for the counseling that must be initiated for the phlebotomist that has the needle stick. So it's still well worth the healthcare institution to promote use of safety engineered devices, to train the phlebotomy staff appropriately in the use of these safety devices. So again, we remove our needles from our holders. We don't want to reuse holders. We don't want to break, manipulate, or recap our needles. We want to use the safety devices that are provided with our needles. We dispose of the holder and the needle immediately after use. We want to sometimes have to modify our work practices. So instead of using a two-handed activation, or instead of maybe switching our hands during the venipuncture procedure, we might have to modify how we perform the venipuncture to effectively use the safety devices and to ensure our own safety while we're completing the procedure. It's beyond the scope of what I can do during this webinar to address all of the equipment that we use, but I do have just a few comments about syringes, our winged infusion sets or butterflies, and then our capillary blood collection. Of course, using syringes, there is still a place to use syringes when we have difficult veins or different areas that we try to access on the patient, but they are associated with a high rate of exposure to needle sticks, so it's important to be safe with them, to use needles with syringes that have safety devices, to use a transfer device when we fill our evacuated tubes. Winged infusion sets or butterflies are also associated with a high rate of accidental needle sticks, and actually this is higher than with the syringe. And of course there are numerous advantages to using the butterfly, but I just want to highlight that there are risks associated from a safety standpoint too. So it's important to properly activate safety components of the needle to prevent needle stick injury. And to just give you an idea of what I'm talking about with the high risk for needle stick injury, in a publication that's released by the Center for Phlebotomy Education called Phlebotomy Today STAT, and this came out in May 2010, there was a comparison of needle stick exposures using a traditional needle and holder versus a butterfly. And just to cite for you, in 2007, 1.7% needle stick injuries occurred with the needle and the holder traditional assembly, and 5.5% needle stick injuries with the butterfly. And there are other statistics cited for other years too that all across the board show that butterfly needle stick percentages are higher than with the traditional needle and holder. So just a word of caution as we use butterflies in the venipuncture procedure. And then finally, capillary blood collection devices also have safety features. We should use devices that have retractable safety blades. The devices, of course, should be discarded in appropriate sharps containers immediately after we use them. And just going back to gloves for a minute, we always, of course, want to use gloves with these devices as well. Well, I just hope that you're all still out there with me. And this is just a little cartoon. One of the things I like to do when I'm not talking phlebotomy or hematology or anything else is I do some running. So I'm just hoping you're all following me along here. So the next section I'd like to discuss are specific situations we run into with patients. And I don't mean the, well, problem patients from the standpoint sometimes there is some agitation or other issues with the patients, but then there can be situations and problems that arise within the patient that might be beyond their control. And as good phlebotomists, we have to know how to interact appropriately. So I'm going to walk through each one of these situations, and of course, as we get to the end, if you have questions that relate to any of the information that's presented, as Holly mentioned, please bring those forth. So let's look first at a patient that has burns. And of course, the first thing to do is to avoid the burn area altogether if you can, because it's going to be very sensitive. It's an area that is even more susceptible to infection. So if we have to use finger puncture, if the sample amount will allow that, then it might be better to do that. Of course, patients that have burns can also be very painful for them to have the venipuncture performed. Related to this would be scarred areas, so veins might be difficult to palpate in these areas, so we might have to look for other sites if possible. The patient that has cast on a limb or has dressings, the tourniquet can be applied to the same arm, but it can inhibit the blood flow, and so it's really not a good idea to do that. It is best to avoid that arm that might have the cast or dressings. So again, the tourniquet can cause some problems in blood flow, so it's best to avoid that. If the patient stops breathing during the venipuncture, of course, you want to call for help immediately and cease collecting the sample. And if you are qualified to begin mouth-to-mouth resuscitation, that might be necessary. The patient that has seizures or convulsions, immediately terminate the collection procedure, apply pressure to that collection site. It may be necessary to call for some help. You do not want to leave the patient. Of course, you don't want to restrain the patient, but try to keep the patient from injuring themselves. There is a certain amount of risk that the patient can jerk or move abruptly, and the needle will puncture either you as the phlebotomist or could puncture the patient in a different site. Mentally disturbed patients also provide a challenge. At times, it's a good idea to check with nursing personnel before you approach the mentally disturbed patient to make sure that you don't need someone there with you, and follow institutional policies. Patients sometimes bleed excessively, particularly if they are on anticoagulants or if they're taking high doses of arthritis medications. And so I'm talking about patients that bleed for greater than 5 minutes. So do not leave the patient until the bleeding stops or a nurse or another healthcare provider is there to assume responsibility. But it is ultimately the responsibility of the phlebotomist to make sure that the bleeding is stopped or there is another person there. Of course, the bleeding can potentially expose the phlebotomist to a greater risk of encountering bloodborne pathogens, so be mindful of universal precautions always. Fainting is another issue that can occur with patients, or another problem. If the patient has a history of fainting during blood collection, have them lie down. Do not have them sit. Hopefully, patients that have this history will let you know, and I know that's been my experience. They will say, I have this, I faint every time. So hopefully they will let you know. If the patient does faint during the procedure, of course, terminate the blood collection procedure, lower the patient's head between their knees. They should breathe deeply, loosen any tight clothing they might have them lay down if possible, maybe have a wet towel if you can find one to put on their forehead, offer some water or juice, and you may need to get help from a colleague. Stay with the patient for at least 15 minutes. They should not drive at least for 30 minutes. You want to make sure they're fully recovered before you allow them to leave the venipuncture area. You may need to complete an incident report if that's the policy of your institution. The Clinical and Laboratory Standards Institute states now that the use of ammonia inhalants should not be used. And the reason behind this is that patients that are asthmatic can adversely react to the ammonium inhalant. And since we don't know if a patient may be asthmatic or not, it's just best to be conservative and not use ammonium inhalants for any patient that has fainted. If the patient becomes nauseated or vomits, you want to try to make them as comfortable as possible, get an emesis basin if necessary, and give them some water if that would help. And then if you need any help from someone else, get that as necessary. Now, the bariatric patient or the patient that is obese can provide some particular challenges to the phlebotomist, and it's estimated that 34% of adults in the United States are overweight, and 17% of children actually have a body mass index greater than 30%. So we're talking about a significant group in the population. So it's important to palpate very carefully on patients that fall into this category. Sometimes these individuals know the best location for their veins. It's not appropriate to smack or to tap the vein. This can cause bruising of the veins. It also doesn't convey a very professional approach from the standpoint of the phlebotomist. We do not want to attempt a venipuncture just blindly without knowing where we're going. We don't want to probe because we can cause tissue damage, hemolysis to our samples. So it's important to consider these situations. It may be necessary to use a longer tourniquet, maybe a longer needle to access some veins that might be deeper. It also can help sometimes to have the patient fully extend their arm and get the underlying musculature to force up the veins and make them closer to the surface. Sometimes it also helps to pre-warm the venipuncture site, and that helps the veins become more prominent. Patients that have tremors, most likely you will need someone to help you hold the patient's arm so that you can obtain the sample. The patient that has arthritis may not be able to extend their arm, and their arm may be bent, so you may have to look for an alternate site or look for the other arm. And it's a certain amount of risk, of course, if you try to puncture a bent arm, because the needle could go right through the vein if it's at too steep an angle. So there can be challenges with the arthritic patient. Patients that are unconscious or unresponsive, I think the best thing to consider in this case is to still talk to the patient as if they were responsive, as if they could hear, because they may be able to still hear you. So communicate still with the patient, but also be prepared that they may jerk or they may move once the needle enters their arm. When we talked about patients that have mastectomy, one of the important things to keep in mind here is that a patient that has a mastectomy affects their blood collection site for their entire life. There's no statute of limitations on a mastectomy, because during the mastectomy, lymphostasis and edema can also form because the patient during the mastectomy also has lymph nodes removed. And lymph nodes are important in draining fluid from tissues. And so when they are not there, fluid can accumulate at the site of the mastectomy. If the patient has a double mastectomy, we may need to check with their physician on which arm or which site it may be better to use. Sometimes it might be necessary to do a finger puncture if the sample volume warrants that. The other thing to consider with mastectomy in patients is that collecting blood from the same site as the mastectomy can be painful for the patient. So again, we want to avoid that. The agitated and uncooperative patient can occur for many reasons. The patient can be upset over news that they just received about their diagnosis. They could be upset over repeated blood collections. We could even have patients that are agitated because they are high on some kind of medications or drugs or alcohol. So always keep in mind that you might need help with these individuals. Also keep in mind that they have the right to refuse to have their blood collected, and we need to respect that. So there can be injury to the patient or to yourself as a phlebotomist if you do not have cooperation of the patient. Patients that have IVs, intravenous devices, or they have vascular access devices like indwelling lines and heparin locks and PICCs, the first choice, of course, with an IV and these other devices is to draw the specimen from the other arm entirely, if that is available. If you must draw from the same arm as the IV, draw below the site, because as fluid mixes with, it will dilute the blood and could affect the test results that are being collected. Sometimes the IV line can be disconnected by a nurse or a physician and then the blood collected, but it's important to make note that this procedure was instituted in case there are some unusual results that are reported from the sample that is collected this way. It is important that phlebotomists not draw blood from vascular access devices without having complete and thorough and documented training to be able to do so. Sometimes the patients give us special requests, so they want us to do a finger stick or they want a certain phlebotomist or they need a certain site for the sample. And I think the best approach always is to deal with these requests in a courteous and tactful manner and keep the patient care as our underlying concern. But I think the other thing to remember is that as a phlebotomist, we are the experts, and we know the standards. We know the standard of patient care. And for instance, the patient may not know that if they have a mastectomy, that collecting blood on that site could not be good because of lymphostasis. So we know the proper procedures. So you have to strike a balance between honoring the patient's request, but also keeping within the standard of patient care. I want to spend a little bit extra time on the cancer patient because unfortunately we encounter these patients all too often in the phlebotomy setting. First of all, the veins in a cancer patient can often be very difficult to locate. The veins can be fragile, they're small, they can be hard to anchor. The chemotherapy can affect the circulatory system in our cancer patients, and so that in turn affects our access to their veins. So we want to be sure we use appropriate equipment, use appropriate technique. We may need to extend their elbow fully so we get, again, the veins to rise to the upper part of the antecubital area in the forearm. We also have to consider that the veins are going to be hard to access because they tend to collapse, so we may need to use special devices like a syringe. We may need to have smaller vacutainers or evacuated tubes available to collect smaller volumes of sample. Sometimes the hands and fingers and even the arms of our cancer patients can be cold. These patients often have lost weight. They've lost fatty tissue that can support and warm their veins, and so it can be more difficult to access their veins because they can be cold. So sometimes we might want to use warm compresses, hot blankets, and warmer even our hands, okay, as we deal with these patients. The cancer patients can also tend to bleed longer. The chemotherapeutic drugs often reduce the platelet count and can cause excessive bleeding. So we want to be careful and be mindful of that with our cancer patients. They can also have swollen hands and arms because sometimes they tend to retain fluid. So we have to consider that as well. The other special patient population that I want to talk a little bit about is the geriatric patient. And it is estimated that the elderly comprise nearly 39.6 million, almost 40 million people in the United States. These are individuals over 65. So in the United States, as estimated in 2009, there are nearly 40 million people over 65. And this represents 30% of the population. So we're talking again about a significant group that we need to address. There are many physiological changes that occur in patients and in people in general as we age. And these changes can certainly impact blood collection procedures. Skin loses elasticity, it loses moisture, it loses supportive connective tissue. This means that veins can roll. The veins can also become more fragile due to decrease in peripheral circulation. The vessels can also become narrowed by atherosclerosis. The elderly can be more prone to hematomas too because of this loss of elasticity. The vessels do not constrict around the needle puncture site or that injured site as well as they do in younger individuals, and that causes the veins to be leaky and hematomas can form. There can be loss of muscle tone, and veins can tend to collapse because of that. And sometimes we need then to consider using a more shallow needle insertion into our veins for these group of people. The elderly can also become cold or chilled, so warming the site before collection may also be necessary. Okay, at this time, I wanted to introduce a case study to get you to think a little bit and not just to hear me talking about all of these areas. So we have a case study, and I'm just going to let you read through this. I don't think I need to read it. So I'll give you just a few seconds here to read the case. And we'll look at the second part. Okay, and here's a little quiz that goes along with the case. So what is the best course of action for this phlebotomist? A, approach the patient again. That sample must be collected. B, activate the needle safety device. Since the needle is exposed and dangerous, then exit the room. C, make sure the patient has stopped bleeding, then exit the room. And D, exit the room immediately. So all of you can jot down what you think the appropriate response is. And then let's discuss this. Well, I guess I'll be discussing it, and you can ask some questions maybe later. Certainly, approaching the patient again and collecting that sample, or A, is not what we want to do. It will not be that important to collect the sample at that time. It would be important to activate the needle device, or the safety device on the needle, since the needle is exposed, and then exit the room. It would also be appropriate to make sure the patient stopped bleeding, but most likely there is not a lot of bleeding if the needle had just been inserted, probably not yet completing the procedure. And then exit the room immediately could also be an option, but the best choice would be, in my mind, B, activate that safety device and actually get out of the room. Well, this was an incident that did happen to me, and what I did at the time was, and this was actually before there were safety devices, I just actually got out of that room. And then I obtained some healthcare providers, the nursing staff went back in to make sure the patient was okay and was not bleeding. But it is an interesting situation to run into. So hopefully if any of you have questions about this or have a different approach to this, you will bring that up at the question and answer period at the end. Another cue that I wanted to talk about a little bit is communication. And of course, this is very important skill, a very important skill for the phlebotomist. And even though the technical skill of collecting the sample is important, phlebotomists also need to be able to communicate. And that's why I wanted to spend some time with this, because we must convey essential information to the patient, but we also need to make sure that the patient understands directions and is following what we need to tell them. So a few comments about barriers in communication. Of course, language. And sometimes when we think language, we think of just the phlebotomist speaking a different language versus the patient. But there can be other language barriers. For instance, using jargon or using medical terms that the common layperson may not use. So we want to be sure that we try to avoid using acronyms and terms that our patients may not be familiar with. Sometimes we may have to get some accommodations to be able to complete the procedure. So if we need a translator or we need to write down the information, that might become important. It's also important to properly transmit what we're trying to convey to the patient. So we need to speak clearly, we need to speak understandably, we need to speak loud enough for the patient. And this, I think, becomes particularly important with that geriatric patient who may have loss of hearing and needs to, and may have trouble understanding us. So that becomes important. If the patient has particular disabilities, as mentioned, geriatric with hearing impaired, then we may need to write instructions, or we may need to write down our statements. It is possible, too, that the patient might be visually impaired, and so we might need to use Braille or have individuals that help us to communicate with this particular patient. It's also important, I think, to think about the visually impaired person being able to still hear, so that we don't want to necessarily raise our voice when speaking to them. We want to speak directly to them and describe thoroughly what we're going to do and be prepared for questions. The other thing I think is important when we're communicating with our patients is to use open-ended questions. And this is in contrast to closed-end questions. So a closed-end question is one that can be answered simply with a yes or no. So instead of saying, are you feeling okay now, after you finish the venipuncture procedure, the patient can just say yes or no. You want to say, please tell me how you're feeling right now. Or is there a part of this procedure you would like me to repeat, or part of something we need to go over again? So give the patient the opportunity to explain a little bit and not ask them a question simply answered by yes or no. For one thing, they may not completely understand even what you're asking and may just say yes because they're not sure. It's also important in communication to limit distractions. And in today's society, we certainly have a lot of noises, TVs and radios, and that can be in patient rooms, or there's a busy hallway, or there's other people talking, or people are talking on cell phones. So as much as possible, it's important to limit or restrict these distracting noises, because they can interfere with our communications with our patients. It's also important to think about the age of our patient. And of course, talking to children is going to be much different than talking to adults and then talking to the elderly. And children can be treated appropriately for their age and can be afraid and anxious, and so treat them as much as possible as adults. And on the other hand, we don't want to treat the elderly like they are children and they can't understand us. They may not hear us, but doesn't mean they don't understand us. And then our tone of voice, I think, is very important, as well as the pace we use in our voice and our volume. Our tone should match our spoken words. We want to use a nice inflection or pitch. We don't want to convey frustration or sarcasm with our patients. We want to be calm. We want to be confident. And of course, there's the nonverbal communication. And this is basically what I'm referring to as body language. So, there are estimates that suggest that what we say, our words, comprise only 10 to 20% of our communication. But our nonverbal messages can account for as much as 80 to 90%. And so you don't have the opportunity of seeing my nonverbal communication. So but I think I'm doing okay. I'm trying to even look professional, I guess, even though you can't see me. But some things we can do to be communicating effectively non-verbally, of course, is to smile. And I'm sure many of you have heard that it takes fewer muscles to frown than it does to smile. So we can exercise even by smiling. We want to use eye contact, can build trust with our patients. It encourages honesty and trustworthiness. So, and I think these communication techniques can be used beyond the phlebotomy setting too, because we all have to interact with each other. We want to approach and face our patients, of course, directly. It shows respect for them. We want to respect the patient's comfort zone or their space around them. And sometimes a stranger getting too close can make a patient feel uncomfortable. They can be nervous, they can be anxious, afraid, and they're already maybe anxious, afraid because of the healthcare situation that they are in. We also have to be aware that comfort zones can vary for different cultures, and so we have to be open and recognize that. We want to use a gentle, soothing touch when we're positioning our patients for the venipuncture or whatever collection we're going to be performing. And this is very important. We have a big opportunity as phlebotomists to display compassion through our touch with our patients by being gentle. Even with gloves on, I think we can be gentle. We also have to be aware of our negative body language, and this can display a lot to our patients and to other people as well. So nervous behaviors, in turn, can make our patients nervous. So if we're squirming or we're tapping on, tapping a pencil or a pen, or we're tapping our foot, so that can increase the patient's anxiety. Certain breathing patterns, like if we, a real deep sigh, can convey boredom or frustration or reluctance. So we want to be careful about that, especially if the patient is already a challenge for us because they're agitated or uncooperative. There are numerous other actions that I'm sure you can think of that display behavior that is non-professional. So frequently looks at a clock and crossed arms and stretching and yawning and chewing gum and thumbing through papers. All of these can show distraction with the procedure and not really being interested in not only our patient, but other people that we are dealing with. And just imagine that if our patient displayed some of these to us, how we might feel. So what can we do to help improve our communication techniques? Well, developing good listening skills does take work, and it does take practice. So active listening is actually paraphrasing to understand what the patient or whomever we are communicating with, so that they understand what we were saying. We can focus on the content and not the presentation so much. What is the message, that is being conveyed? Maintaining eye contact that expresses interest. Again, if we are rolling our eyes or wandering our eyes or gazing out the window or the ceiling, that can display boredom or inattention. So eye contact can again show us show whom we are communicating with that we are concerned. We want to, again, minimize those external distractions with TVs and phones and cell phones and so forth. We want to question the speaker, and that can show that we are really, interested. It can reassure the speaker. It tells them that we are really trying to understand what they are conveying. Giving feedback can verify the conversation. It allows us to clarify what is being stated. And then, as I said at the onset, practicing and developing these active listening skills does take some time and some effort. All right, here's the second case study that I'd like to introduce. So again, I'll let you read this. In our second part, and here's our little quiz. So what communication skill did the phlebotomy student forget? A, telling the patient what size needle she was going to use. B, using a soothing touch. C, respecting the patient's comfort zone. Or D, listening to the patient. Well, again, a little hard to discuss, so I'll share my views of this. First of all, I think that we're not given enough in the case study to know the actual size of the needle. We know that a butterfly was not used. As far as soothing touch, we're not given enough information. The implication would be that there were no issues with that because the complaint was because of the needle, type of needle, and not how the patient was manipulated. Respecting the patient's comfort zone, again, we were not given any information that indicated that was an issue. So to me, it was D. that the phlebotomy student did not listen to the patient. And this was another situation that actually happened to me, and I was the phlebotomy student. I was young. I thought I knew better than the patient. And as I cited previously, or stated previously, there's a balance between taking into consideration the patient's request and then doing what is within the standard of care. And there was certainly no reason that I couldn't have used the appropriate needle as requested by the patient. I just thought there was no need to do that. So it was a very important lesson for me at a young age, and I think continues today as a lesson for all of us, that if the patient's request is reasonable, we can honor it and we should listen to them. Okay, as we start to conclude today, I want you to think for just a minute here or so that, and I hope certainly for all of you, that you've learned some bit of information, or maybe you were reminded about something that you had learned maybe long ago or maybe not so long ago that maybe you hadn't remembered and you've been reminded about it. So I want you to take just 30 seconds so, or a little bit less, to write down something that hit you today. Is there something out there that I've said, that we've discussed today, that you've been reminded of, or something new that you learned? So I want you to write it down. I want you to take it with you when you walk out the room today. Well, I thank you for doing that. I'm assuming all of you out there have done that, and you had something to write down. I've just provided for you bibliography and references for your information, and I certainly want to thank all of you for your dedication to the phlebotomy profession. So at this point, I'll take any questions or comments on the case studies.
Can you hear me?
Yes.
Hello?
Yes.
Okay. I have a question regarding the obese patient.
Yes.
I had a lead tell me one time for obese patients that to double tourniquet. Is that appropriate?
If doubling the tourniquet means tying the ends together to make it longer, yes.
No.
It was
they were meaning like taking
one on
two
top
tourniquets.
Of the other?
Right.
Oh.
Taking two tourniquets and putting it on, because sometimes what I was explained to they're really large arms. It's almost like the tourniquet gets lost in their arm.
Yes.
And if you double tourniquet it, makes it just a little bit thicker, and it doesn't hurt the patient as much, and it causes just a little bit more pressure to make those pop out. I was just wondering what your take on that was.
Well, that's something I haven't heard of before. And I think if there's not...
I hadn't either.
Yeah, if there's not an adverse reaction to the, for the patient, that it's not going to hurt anymore.
Right.
Again, we always have to be concerned about leaving that tourniquet on too long.
Right.
I think probably what I would do initially is just to make sure that I have the first tourniquet on tight enough. And try to go from there. And position the arm straight enough so that the elbow is straight, so that we get all the musculature underneath to try and pump up those veins. But if none of that is working, I guess I don't see a problem with it, as long as it's not hurting the patient. I have to be honest, I haven't really heard of that before.
Yeah, that was something new to me. And just one other thing that I have found helpful, especially with not so much, with outpatients too, but with inpatients, especially when they're really sick and don't feel good, and the geriatric, is if you can take either a washcloth or their sleeve and use the sleeve to put the tourniquet around, it's more comfortable for them.
Right. Yeah, thank you for sharing that. That's a good tip to help the patient be more comfortable. Absolutely.
Right.
And that's good to be thinking always about, our patients and making them as comfortable as they can be. Yeah, thank you. That's good. Just like the color.
Okay, great. Thank you so much.
You're welcome.
Yeah, got it.
Thank you.
All right. Thank you. You take care.
Uh-huh.